Welcome to the Rotary Club of Jonesboro, five-time winner, Club of the Year. Inspirational moment from Francis of Assisi. Start by doing what's necessary, then do what's possible, and suddenly you're doing the impossible. Okay, our program today, mitigating the spread of the Delta variant. Dr. Shane Speights, Dana Kennedy will introduce him.
It is truly an honor to introduce Dr. Speights. He is a very busy man, has been for the last year and a half, I think. Dr. Speights received his medical degree from the University of Health Sciences College of Osteopathic Medicine in Kansas City, Missouri. He is board certified in family medicine and completed his residency training at the University of Arkansas Medical Science Northeast Family Medicine Residency at St. Bernard's. Dr. Speights also holds a Bachelor of Arts degree in Business Administration from Henderson State University from Arkadelphia. As the site dean for NYIT College of Medicine at Arkansas State, he leads faculty and students in academic and co-curricular activities while engaging in community outreach with hospitals and physicians in the Jonesboro and Greater Delta area. Previously, Dr. Speights served as Associate Dean of Clinical Education at NYIT College of Medicine at ASU. Welcome, Dr. Speights.
Thank you so much. Delighted to be here. Make sure that everybody can hear me, and I'll flip over my slides. First of all, there is good news on coffee. For those of you that may or may not be aware, there's actually some latest research out in the last month or two. There's really good research on coffee and the benefits of coffee. I'll use that as a teaser. You can invite me back later, like after COVID, and I can talk to you about all the benefits of coffee and what we're seeing in the coffee research. But for now, we'll go ahead and talk about COVID because that seems to be the fire in front of us for everyone. So let me go ahead and share my screen and we'll get started. All right, just to get a little update here. I always think it's important when we talk about COVID that we kind of start nationally and then kind of move in. And I usually talk globally as well, but I won't go that far out right now because I'm just in the interest of time. This is what's going on around the country. First of all, if you're not keeping up with this, Florida and Louisiana are blowing up right now. They are seeing cases that they have not seen ever during this COVID pandemic. You see Florida there in the top left-hand corner. It is just relentless in that if you have a trip planned to Florida, you might want to rethink it because they have significant spread of the Delta variant throughout that state. There are obviously certain hotspots, and I'll show you what the state of Arkansas looks like. But we're seeing the same in Louisiana. And for those of you that haven't been watching that either, they've had a significant impact on their hospitals. Lady of the Lake Hospital, their children's hospitals, a lot of their major hospital systems are overcrowded and they have limited resources for ICU beds as well. We're starting to see the same in the state of Arkansas. I think I saw the posts yesterday or so about 8 ICU beds being open here in Arkansas. You see the graph there in the center. The U.S. overall is, of course, seeing an increase, largely driven by the southern states. The map in the top right-hand corner, the darker areas show you where the larger amount of outbreak is. And you can see largely it's centered around Florida, Louisiana, southern parts of Mississippi, Alabama, of course, throughout Arkansas and Missouri. It's starting to pick up as well in Texas. So being spread largely from the southern states throughout the rest of the country. We're seeing hospitalizations go up as well. Right now, the U.S. is quoting about a 50% fully vaccinated rate. So in terms of all of the population, about 50% are fully vaccinated. But we are still seeing, unfortunately, here in the U.S. over 100,000 cases a day, and we haven't seen that really since back sometime in early February, the end of January. Moving closer to home here in Arkansas, the map in the top right-hand corner, the darker the area, the more outbreak and the more cases there are there. Should be no surprise to you. The areas that are shaded darker are also the more metropolitan areas by and large. Central Arkansas, Northwest Arkansas, and Northeast Arkansas are seeing the most spread. you can see that we are seeing cases now getting close to what we were at the 1st of January. And I'll talk to you a little bit about the peak, or where we think that peak might be toward the end of my slideshow, because there's a lot of debate over that. We're just not quite sure because we've not gone through this before with this variant. Unfortunately, what we're dealing with as well is the hospitalizations you see on the right-hand side there. A significant spike in hospitalizations, getting close to where we were there toward the 1st of January. We hit a peak of hospitalizations in our state really right there about the August area. So between July there, you see the significant peak there. We've not hit that yet. We're getting close to where we were back in the January timeframe, averaging about 2,300 cases per day. As a comparison here, I guess in May or so, we were only averaging about 180 cases a day. So much more significant spread, again, due to the Delta variant. Deaths have gone up as well. That should be no surprise. Remember, deaths are reported later. And so you'll see cases first, followed by hospitalizations, and then deaths usually lag several weeks. And so we can expect the numbers of deaths to go up over the coming weeks and month or so. One of the things that's challenging here in Arkansas is our low vaccination rate. Here in the state, we're about 37% fully vaccinated. Now, drilling down even closer to home. Oh, and last thing on this slide there at the middle, at the bottom, 65 and up. Almost 70% of individuals that are 65 and older are fully vaccinated in the entire state of Arkansas. I want you to hang on to that number now as we drill down closer to home in Craighead County. These are the numbers. This is the graph in Craighead County where you see where our cases are. We've been hitting close to 100 plus cases over the last couple of days. You can see we weren't hitting that. Really, the last time we were seeing that was back in the December timeframe. The 1st of December is when we were seeing numbers this high. We were seeing low numbers just like the rest of the state was before this Delta variant hit us. And so we're seeing significant spread here in Craighead County in Northeast Arkansas. And most of that is driven due to this number right here. We only have a fully vaccinated rate of 29% in Craighead County. If you need more evidence about mask wearing or the need for it, just remember, if you are fully vaccinated, you are in the small minority of those in Craighead County. An even more disturbing number is in the bottom right. Remember, 68%, almost 70% of those over the age of 65 in the state of Arkansas are fully vaccinated. Only 56% over the age of 65 are fully vaccinated in Craighead County. That's not going to bode well for our hospitals or those individuals over the age of 65 who will likely get infected by this Delta variant. And I'll talk to you about that actually now moving to the next slide. What is this Delta variant? Why is it such a big deal? Why are we dealing with it now? Well, first of all, let me go ahead and draw your attention to the top left-hand corner, that pink graph up there. And it may be hard to see, and I apologize. I don't know there at the Embassy Suites how well you can see this. But the point is you see these waves that occurred, these trends that occurred in the U.S. This is a U.S. map. And you saw this high amount of spread that occurred there between November and really into February. Lots of virus was spread around. That's where variants come from. When you have a whole lot of people get sick and pass a virus around in large populations, and we're talking about millions of people, that's where the virus has a chance to change its genetic code as it jumps from person to person. And when it makes those changes, that's where variants come from. Now, it's not uncommon for a virus to change its genetic code. And usually when it makes those changes, it's not really significant for us being humans. However, when you have so much spread that we saw during that time period, it was bound to happen that we were going to have a variant or a genetic change that was going to be for the worse for us. And that's what happened. Actually, this is where the Delta variant came from, was about December. Remember, what we were seeing in the U.S. was no different than what we were seeing globally. This Delta variant was identified in December of 2020, and it really hit hit the U.S. in about March. In May, only about 1.3% of our COVID cases were the Delta variant. In June, only about 10% of the COVID cases in the entire country were the Delta variant. 1 month later, 83%, almost 82%. And now we're closer to 95 or higher. So this is what we call exponential spread. This is a very, very contagious virus. I'll talk about that in just a second. But the difference is there's different mutations on the spike protein, which is how the virus infects your cells. We make a big deal about the spike protein because that's what's kind of a lock and key system. That's what the virus uses to actually get into human cells and cause an infection. The virus itself can't really reproduce that well on its own. It has to hijack your cells in your body to be able to do that. And so it uses that spike protein to get into the cells to really use your, for lack of a better term, your machinery to create a virus factory. In the Chinese study, when we compared the old COVID strain to what we're seeing in the Delta variant, there's about 1,000 times more virus that was isolated in the nose and the mouth of individuals with the Delta variant as opposed to the original strain. So a lot more virus, and here it equates to being a lot more contagious. What about symptoms? Are the symptoms the same? Interestingly, not too many people are having, some of them are, not too many are having that loss of smell and taste that we saw so much last year, and not a ton of cough. Some people just have a runny nose or a headache. Sore throat is interesting. A lot of people are having a sore throat. You think it's strep or you think it's mono, and it's really not. It's actually COVID. Fever, about plus or minus. Some people have fever, some people don't. We do see that for those that are fully vaccinated, they usually have much milder symptoms. And so sometimes they can say, it's just allergies. I always have them this time of year, or, oh, it's just a little summer cold. And they may just kind of pass it off as something like that, when truly it's COVID and it's just their vaccine was protecting them. The reason why that we're seeing, or one of the reasons why we're seeing it more contagious, and the CDC has commented and said it's as contagious as chickenpox. I've got a graph I'm going to show you on the next slide. This is a good way to think about it. With the original COVID, if I was sick with COVID, with the original COVID strain, I would typically infect 2 to 3 people. So I could probably make 2 to 3 people sick, which is not good, but 2 to 3 people would get sick for every one person like me that was sick. Now with the Delta variant, for every one person that's sick with the Delta variant, I'm going to infect 5 to 8 people. That's much more contagious than what we've been dealing with, which is why you're seeing these huge spikes in infections and you're seeing this rapid spread across communities. Back in the day, I say back in the day, last year, if you had an event outside, you were pretty safe from getting COVID. As a matter of fact, being here in Arkansas, being outside a lot, that was actually considered very safe. I would have even told you back then, look, if you're outside, your risk of catching COVID is low. That's not the case now. We have studies now, one in particular that came out of a wedding that was hosted in Houston that had right at 90-something people or so. They were all fully vaccinated, and it was an outdoor wedding. They still had 4 infections and 1 individual die from a fully vaccinated event that was held outdoors. So this is not the same virus we dealt with last year. The other thing is that we think it's probably a little more severe. At first, we weren't sure. We didn't have, we don't like to make claims or comments unless you have the data to support it. Because the good Lord knows there's plenty of misinformation, even disinformation out there. It's hard for people to figure this stuff out. It takes a lot of data and research and combing through all this to really figure out what the absolute answer is. But we have 3 studies, specifically out of Singapore, Canada, and Scotland, that have had the Delta variant, that it seems like there is a slight increase in hospitalization rates. And that's actually shown on this slide here. This is the slide of the Delta variant compared to other infectious diseases like the common cold, polio, seasonal flu, chickenpox, even the original strain of coronavirus. Now, what I want you to see here is along the bottom, or the x-axis here, along the bottom, as you move to the right, that means that the virus spreads more quickly. It's more quickly spread from person to person. As you move along the y-axis from the bottom to the top, that means it's more deadly. So obviously where you don't want to be is up here in the top right-hand corner, where you have a rapidly spreading disease that kills people. This is the Delta variant right here in the center. It's such a large box because right now it's so variable. We can't really put a dot there, but we do know it's as infectious as chickenpox. We also know it's more deadly than chickenpox. It's more deadly than polio, seasonal flu, the 2009 influenza outbreak, and certainly more than the common cold. We are not seeing death rates up to the level of the 1918 Spanish influenza or, smallpox, Ebola, things like that. But what you can see here, and the point behind this slide is This is not the same virus we were dealing with just last year, which is the gray box over here to the left, where it shows the original version of the coronavirus. And so I thought this was a great graph. This actually came from a CDC slide deck that was, I'm going to say, accidentally released about a week and a half ago. So when we talk more about the Delta variant, what is it we need to know? I'm going to talk more about the vaccines and how well they work in a couple of slides. So let's hold on that topic. You hear a lot about herd immunity, the top right-hand corner that shows an example of herd immunity and how it works. We're probably not going to get herd immunity. It was kind of a pipe dream to get herd immunity with the original COVID, the COVID virus, because we had such a few people that really would take up the vaccine. Now it's almost going to be impossible. You need about 83% of the population to have some sort of immunity. So herd immunity in the near future is not going to happen. And when I say near future, the next 6 to 12 months is not going to happen. Vaccination will help. People getting sick and creating an immunity will help, but we're not going to reach herd immunity to the level we can just stop this from happening. The Delta variant is going to have to play itself out, and it's going to play itself out rapidly in the next 2 weeks. And I'll talk about that in just a second as well. So who's at the highest risk of getting the Delta variant and being hospitalized or dying from it? Well, from what we can tell nationally and internationally, those that are unvaccinated or partially vaccinated and without a history of a prior COVID infection have the highest risk. So if you didn't have COVID in the past and you've not been vaccinated, you are in that high risk group. And that seems to equate for about 90 to 95% of our hospitalizations, even here in Arkansas, even here in Craighead County, in terms of the people that are hospitalized. We do see young adults and children getting it, partially because of the vaccination rate. Kids under 12 can't be vaccinated. There's not a vaccine available for them. So they're at risk of getting infected. And there is a risk of infection. You see a fivefold risk of infection for certain children's groups, 5 to 12 and 18 to 24. But I want to be clear about this, and I want to make sure that this is heard correctly too. From what we can tell, infections in children right now don't seem to be worse. And what I mean is it doesn't seem to be targeting kids particularly. Like, it's not that this virus attacks kids worse than it does adults. It does attack kids, and kids will be hospitalized. That's based on the pure volume of infections you're going to see. So it's like a percentage. So if you have more people get infected, i.e. more kids get infected, and a certain percentage of those kids are going to be hospitalized, then the raw number will be higher based on your percentage. So we will see more kids hospitalized, as we're seeing now, and you will hear about children dying from this. And that's not something we really heard much last year, because you didn't have a lot of kids get infected. So that is something that people need to be aware of. Vaccinated elderly individuals. This is an important risk group. And why is that? Well, because to be honest with you, you still had risk factors based on age and your comorbidities or the underlying diseases that you had. So you were immunocompromised. Specifically, individuals over the age of 65, even those that were fully vaccinated, especially if you were vaccinated very early. And this is where the conversation about booster vaccine comes in. If you were vaccinated back in December of last year, I'll talk about the data behind that, but you may be one that wants to get a booster vaccine. You will hear about booster vaccines. I expect that you will hear from the FDA in the coming weeks that would recommend individuals that are older, immunocompromised, get a booster vaccine. At this point, I would recommend you do, based on the limited data I've seen, but the data that I have seen is positive for elderly individuals or those that are immunocompromised to get a booster dose. And again, I'll talk about that more in just a second. This was new data that came out at the end of July, and it's about individuals who are fully vaccinated and their ability to spread the virus. We didn't know this information until this study came out. Very, very important information. And I've actually got a couple of slides that goes into more detail on it. And basically what it showed was there was an area in Massachusetts that had a high vaccination rate, yet they had significant spread of the Delta variant. And what happened was we found out these individuals were still able to spread the virus significantly over a short amount of time, and whether they knew they were sick or not. Now, here's the important thing. These fully vaccinated individuals, and you see there, total cases are about 470 cases, but now it's risen to 900. 74% of them were fully vaccinated. 79% of those were symptomatic. So 79% had symptoms. I had a runny nose, cough, headache, something like that. But only 4 were hospitalized. So now it's risen to 7 now, but there have been no deaths. The point behind it is the vaccine still does its job in large part. And we were enamored by these vaccines when they first came out because we'd never seen vaccines that did such a great job at not only preventing death and hospitalization, but from actually getting the virus. The point behind the vaccine, the initial idea behind the vaccine, the COVID vaccine specifically, was we didn't want people to go to the hospital. We didn't want you to end up in the ICU. We didn't want you to die from this virus. And so that was the point of it. If it kept you from getting symptoms, that was just icing on the cake. If it kept you from feeling bad, that's just a bonus. But at the end of the day, and maybe you were at home with a cough and a runny nose for a couple of days, didn't feel good, but you weren't in the hospital and you weren't about to die. That was the point of the vaccine. And the vaccines still do that. And they do that even with the Delta variant. I'll talk about that in a second. I'm going to show you a graph that talks about the CT values. You may have heard me speak about CT values before, and I'm trying not to get too deep, but some of this you have to understand to be able to see the data. It's called the cycle threshold, and basically what it means is if I test you for COVID and you're positive, sometimes I have to run the test through the machine multiple times before the positive occurs. The fewer times that I run it through the machine, the more, we'll just say the more positive you are. That gives an example, or excuse me, gives us information that you have a stronger amount of viral load in your body. If I have to run the thing like 50 times for it to turn positive, you don't have a very significant infection. If I have to run it 5 times, it's like, whoa, you got a whopping infection. That's important for the next slide that we're about to show. We're seeing some of the same data, though, that we saw in Massachusetts actually play out across the country, over in San Francisco specifically. But even there, they're only reporting about 1% of the people that were fully vaccinated are actually being hospitalized. This is the slide I was talking about, and this is the data that I think was so important that we're seeing now. And this talks about individuals, and the green line is individuals who are fully vaccinated. So let's say you're fully vaccinated, yet unfortunately you got sick with COVID. You can still spread the virus to somebody else. And in fact, if you look at this on the left-hand side, you see days of illness, you're spreading it as much as somebody who's unvaccinated. So for those first few days, specifically about the day 4.5, day 5 or so, a vaccinated and unvaccinated person who are both sick with the Delta variant are both shedding the virus about the same amount. Now, when you look at the rest of this graph, following out, you see all the red dots, who are all the unvaccinated people. You see they continue to shed it much more significantly than the vaccinated people. You see the curve drops, and it drops pretty significantly after about day 5 or so. But what I think is important is, and we talk about, still some unknowns in this virus, you see people out day 19, day 22, day 25 that are still shedding a significant amount of virus. This again goes back to why are we seeing so many cases and why are we seeing such rapid spread across our country and across our communities? It's because it's so contagious. There's so much more virus, and it's able to infect people and continue to spread at a rapid rate. So being vaccinated certainly does not only protect you, it does protect individuals around you if you happen to get sick from being infected, specifically after about day 5 or so. Now, the CDC guidelines will say, and I'll show this in a second as well, if you are sick, you have to stay home. If you're sick with COVID-19, you stay home a minimum of 10 days. So that 10 days we feel like is a good number that kind of keeps you from shedding to somebody else. Even if you have little to no symptoms at all, you're still home for 10 days. All right, moving on to the vaccines themselves, let's go ahead and start talking about those. Pfizer right now currently is approved for individuals 12 and older. You can expect Moderna to do that. They'll be coming out here in the next few weeks with the same dosing, the same age approval. This was interesting data. And this is where the booster dose conversation comes in. This was a company sponsor. So Pfizer itself tested 44,000 of their volunteers that were in the original test group way back when the vaccine got approved. And they tested them at 6 months after the second dose. They found that through that data that the effectiveness of the vaccine drops about 6% every 2 months, or about 3% a month. And what they found was at 6 months, vaccine efficacy was about 84%. Now, here's what I want to be clear of. What they considered vaccine efficacy was you tested positive and you had any symptoms at all. So even if it was a mild runny nose, even if I just don't feel well, that was considered a positive. So it dropped to 84% there. It still had 97% effectiveness at preventing you from being hospitalized, ICU, intubation, or dying at 6 months. So this is the back and forth that's been going on with the CDC and the FDA and Pfizer. Pfizer's saying, we think you need a booster dose because of the reduced efficacy. CDC and the FDA are saying, wait a minute, you're still showing 97% effectiveness from hospitalization and death, which at the end of the day is what we want out of your vaccine. So that's why this tug of war has been going on back and forth between those groups. I don't know if you've seen that playing out in the media or playing out in the news, but that's the idea behind it. Now, and a New England Journal of Medicine study kind of came out, another third party came out and it kind of confirmed and showed 88% effectiveness about the same time for symptomatic disease, which is similar to what Pfizer showed in their study. Now, Israel, which is interesting because, you know, they kind of sometimes do their own thing and they're a little ahead of us. They already started vaccinating individuals 65 and older, and they started giving them a booster dose. So they started doing that about mid-July. They found a study. They had a separate study in their own database. They have this large health database of all their population. They showed 41% effectiveness at preventing symptomatic disease and 92% effectiveness against severe disease, which would be hospitalization, or excuse me, 92% against hospitalization, 91% against severe disease, which again, hospitalization, ICU, ventilator, that all kind of goes in the same ball there. I think the 41% effectiveness at symptomatic infection is interesting. Remember, that's probably subjective in terms of what you call symptomatic infection versus the 84% that Pfizer was showing. The key is that you still have 92 up to 97% effectiveness by both of these studies at preventing severe disease. And that's what we're seeing here in the US. By and large, fully vaccinated individuals are not the ones being hospitalized. They are not the ones on the ventilator. They are not the ones dying. And so in real world data, we're seeing that to be the case as well. We do expect Pfizer to come out with approval for ages 5 to 11 in the September-October timeframe. We expect them to probably go forward to the FDA with EUA sometime in September, and we expect the FDA to move on that by October, fingers crossed. I've not seen any data on that. I'm very much looking forward to it. I reviewed the data in the younger age group, and the data looked really good, so I'm looking forward to seeing this data when it comes out. Why don't we have FDA approval? What's the big deal about that? What's the government hiding? You know, we got if these vaccines are safe and effective, why don't we have FDA approval? Well, by and large, it takes about 10 months to get FDA approval. And now this was going to be expedited anyway. You know, when I say expedited, red tape removed. They still were going to review the data and scrutinize it. But basically, they were going to get bumped to the top of the line. Remember, they've got a whole queue of things that the FDA approves. And that's why it can take so long. It's because, you know, you got to wait your turn, so to speak. Well, they were going to move these up to the front and expedite review of them is what it was. So they're just going to push them above the latest, you know, treatment for, plantar warts or something like that. And they were going to look at that first. So Pfizer submitted their data May the 7th, Moderna the 1st of June. And so everybody was wondering, why aren't we seeing FDA approval on this? So the water cooler talk is, and the kind of behind the scenes at the federal level is that the FDA wanted to approve all 3 vaccines at the same time. They wanted to approve Pfizer, Moderna, and Johnson & Johnson at the same time. Well, Pfizer's got all their stuff together. Moderna was getting it together, and Johnson & Johnson didn't have their data. So the FDA's dragging their feet, waiting on these other companies to get their data together. Meanwhile, Pfizer's like, what the heck's going on? I've got my data. I submitted it to you. What are we waiting on? Since all that's kind of come out, FDA is now moving forward to review Pfizer's data independent of the other 2. So you can expect Pfizer to come out with FDA approval probably in the coming weeks or so. Don't be surprised if you see that in the next 2 to 4 weeks. Moderna, again, they submitted for approval, for FDA approval June 1st. Not sure when Johnson & Johnson is going to submit for theirs. Johnson & Johnson, there's a little question I'll say about that, and I'm not trying to cause alarm. They initially had out a couple of reports and even a press release that their vaccine covered the Delta variant and showed great efficacy against the Delta variant. And to be honest with you, I didn't see their data, but we were looking at AstraZeneca, which uses the same platform. And the AstraZeneca data looked pretty good against the Delta variant. So people kind of assumed, well, they're probably the same. It's the same kind of platform. It's almost like comparing Moderna to Pfizer. They're probably good. An independent group came out and reviewed their data, and it was out of the NYU actually recently, and it only showed 33% effectiveness at symptomatic disease from the Delta variant, and closer to maybe 50% effective at moderate to severe disease. Well, that's not good. And so that's not what Johnson & Johnson's been putting out. The other thing to remember is that Johnson & Johnson's a one shot. AstraZeneca, though it's the same platform, is 2 shots, which would increase your immunity. So right now, the authors of the study said, look, Johnson & Johnson, you're probably going to need to put a booster out pretty quickly. The authors recommended to use a booster with Moderna or Pfizer. And there's been debate about that. And there's studies going on now. Can you mix and match vaccines? We think the answer is yes. We don't know for sure, but we think the answer is yes. But don't be surprised for individuals that have got the Johnson & Johnson that there's a recommendation that comes out soon that says you need to get a booster's dose. It needs to be with either Pfizer or Moderna. So kind of stay tuned on that piece. When we talk about vaccinated versus unvaccinated, these are actually some CDC slides that came out about a week and a half ago or so that we were able to get a hold of. And it shows the stark difference between individuals that are fully vaccinated, the blue bars in the bottom, the small blue bars in the bottom versus the large green bars on the right-hand side in the unvaccinated numbers. And this is data the CDC has collected throughout the country. And again, it seems to be coinciding with what we're seeing here in Arkansas and even locally. Back to the booster debate. What about that? I've already kind of mentioned that, kind of gone through that, and kind of talked about the mixing of vaccines. Pfizer on their own website put out that they continue to believe that you need a third dose within 6 to 12 months after full vaccination. The FDA and the CDC disagree. I think you will see booster vaccines for all 3 of them come out probably in the next month or so. Don't be surprised at that. Like I said, Israel's already started. I think what you're going to see first is the FDA or the CDC coming out saying that individuals 65 and older, individuals that are immunocompromised, need to get a third or booster dose. I don't know if they'll throw in the J&J, the Johnson & Johnson on that too. But like I said, just expect that in the coming weeks, certainly as we see more spread of the Delta variant. Okay, what about the risk of breakthrough infection in general? I'm fully vaccinated. What's my chance of getting infected? Well, like I said, right now we're showing that severe infections largely are unvaccinated people. That's going to change some. That number is going to go down a little bit, and here's why. When you have those of us that are in that small 29% here in Craighead County, we're surrounded by a lot of people that are unvaccinated that are going to get sick. Well, every time I come in contact with somebody who is sick, I'm rolling the dice. And so for the sake of argument, let's just say it's a 6-sided dice. And if I roll a 6, that means I get sick. So if I'm unlucky to roll a 6, that means that I'm going to get the Delta variant. I roll the dice, I roll a 3. Okay. I roll the dice again, I roll a 4. If I roll the dice enough, I'm probably going to hit a 6 at some point, which means that based on how many people I come in contact with during the day, at some point, I'm probably going to end up rolling dice if I'm out, again, unmasked, unprotected, even though I'm vaccinated. It's just kind of the law of averages. When we look at UK data, we see that, and it wasn't a huge cohort, it was about 3,600, almost 3,700 people at their hospitalized with the Delta variant. About almost 60% were unvaccinated, 22% were fully vaccinated. That's the number we'll probably move to. Right now, we're at 97%, between 90 to 97% in the hospital. I bet that number changes. And I bet because we have so much Delta variant spread that at some point you're going to start seeing these 65, 70, 75-year-olds, even though they're fully vaccinated, they're going to get infected by somebody with the Delta variant, and it's not going to go well, and you're going to end up hospitalized. You still have a significant lower chance of dying or being on the ventilator when you're fully vaccinated. It's just, I've mentioned this several times in terms of trying to explain it. It's like driving your car. There are things that you do that lower your risk of dying in a car accident. You wear your seatbelt, you have a car with airbags, you drive the speed limit, you don't tailgate. There's all these things that you do to reduce your risk of being in an accident. The same thing is true with COVID-19. What can you do to reduce your risk? I carry alcohol-based hand sanitizer in my car. I wear a mask. I'm fully vaccinated. I don't participate in large group events. I'd love to be with you guys right now, I like large group events, but we got to do it. But I chose to do this virtually. And so there's decisions that you make individually that either increase or decrease your risk. And that's what we have to do now, unfortunately. So in terms of the take-home points, yes, there is a risk of reinfection. This is a good point too. For individuals that have had COVID in the past, and I've tried to dispel this as well. People that have had COVID, I got sick with COVID last year, and I think I'm fine. Well, you are to a point. And the antibodies that were produced by your body when you got sick do offer you protection. Current studies show that those antibodies start to go away about 6 months, and they start dropping from there. So if you were sick more than 6 months ago, your antibodies are not protecting you as much as they would have 3 months ago or so. So you're starting to lose your antibody protection. Studies also show that individuals that have had COVID and then get fully vaccinated, those individuals are among the most protected of all groups, even amongst the fully vaccinated people. So the most protected individual is someone who had COVID last year or had COVID earlier part of this year and then got fully vaccinated. Those individuals have the highest level of immunity. But again, still remember here toward the bottom of the slide, individuals that are at high risk of being hospitalized, even that are fully vaccinated. Let's see here. New guidelines from the CDC, masking in public. That's even for fully vaccinated. That's kind of goes back to what I just showed you just now. If you get exposed, this virus spreads more rapidly. It's much more contagious. It also shows up on a COVID test more quickly. About 4 days is the average, which is why the CDC says that if you come in contact with someone who's been COVID positive, you should get tested 3 to 5 days after exposure, and you should wear a mask until you come up negative. Individuals in certain households need to wear masks. And this was a big one too. And I know this is, and I'm going to talk a little bit about this actually as we're closing up. All students, staff, and faculty regardless of vaccination status, need to be masked. Some of this is common sense. Think about your third grade class. You're going to put 25, 26 kids in a classroom, and we know they can't be vaccinated. And we know this virus spreads rapidly and much more rapidly than the one before. This is going to be a mess. And so you're going to see lots of infections, lots of quarantines, and lots of isolation. And actually, we're already seeing that in a school district here in Arkansas. A lot of debate over the Act 1002, which the governor called a special session, hopefully that they could undo that. That was not successful. However, there was a state judge that put that on hold for now. Not sure how that will play out or what the politics are behind that. I think it's unfortunate. I always think it's unfortunate when the health of the public gets mixed up with politics and votes. Just as a reminder, in terms of the CDC, remember what quarantine and isolation are. Kind of dust off those guidelines because that'll be important to know. For those of you that are fully vaccinated, you don't have to worry about quarantine because you don't quarantine. Those that are unvaccinated will still be quarantined. Anybody that gets sick, whether you're vaccinated or not, you still have to stay home for 10 days. And so that's something to remember, certainly for those of you that are employers or that you work with human resources or things like that. You do not test out of going back to work. It's not one of those things where if I test positive today and if I test negative 2 days from now, I can go back to work. The CDC does not recommend, and I agree with this, do not use a test-based strategy to allow yourself back to work. We use a symptom-based strategy with a minimum of 10 days. And the reason why is because the testing can be flawed. And so once you test positive, you're out for 10 days. And then once that 10-day period, depending on your symptoms from that point, you can come back after that point. What about the return to school, which occurs in about a week, actually now? Here in Arkansas, here in Craighead County, we will see schools going back into session about the middle of next week or so. If I remember correctly, I think my wife goes back the middle of next week. We've had a heck of a season with RSV. RSV we normally don't see here now. RSV is more of a cold weather virus. Why are we seeing it now? Well, it's because everybody was wearing masks and staying inside, and we pushed the virus itself, the RSV virus, to the summertime, and so that's what happened. And you're going to see some of that too. You'll see kind of a flip flop of some of our normal infections. I mean, I think I had somebody that I was talking to worked in a clinic picked up an influenza B just a few weeks ago. That's not surprising as people stop wearing masks, stop hand washing, that sort of thing. But the big thing is that on the Delta variant, for those that are involved involved in this, don't think that what you did last year is going to necessarily protect you from this year. It's not the same virus for sure. Again, those under 12 cannot be vaccinated. The American Academy of Pediatrics and the CDC have both said that all children over the age of 2 should wear masks regardless of vaccination status. CDC has said that includes staff and faculty. The graph on the far right-hand side is a reminder. These are the deaths caused by COVID. For those 0 to 17, since the onset of the pandemic, it's only been, and not that they're to be taken lightly, 340 deaths. That's not a lot of deaths. It's not. The pediatric infections for COVID-19, by and large, are not severe. However, when you have a large number of kids get infected, you can expect the number of severe cases will go up. You can expect the number of deaths will go up compared to the virus we dealt with last year. So that sometimes is a hard concept. That's the reason why I keep reiterating it. At-risk individuals should stay at home. What is there anything we can learn to know what to expect? Yeah, the data out of summer camps is not reassuring at all. We've got in summer camps, largely you're spending time outside. It's not an indoor camp. Lots of infections around the state. Even, I don't know if you're familiar with this, our Arkansas National Guard. Most of them were sent to Louisiana down there. A good number of them got infected with COVID. And these were all outdoor events. These were in austere environments. They were doing exercises in fields. And they were out doing actually, sleeping outside intense military style events, and still had a large number of infections. And so that doesn't bode well with us. When we look at the graph itself, and this is for the state of Arkansas, and we see the changing demographic, on the right-hand side, what I want to draw your attention to, and this is by age in terms of who's getting the Delta variant, you're still seeing 18 to 29. 18 to 29, that's a new group since the old one. You see there, follow back to May, the group that was getting it and spreading it was really your 16 to 17-year-olds. So now it's 18 to 29, still the 30 to 39, 40 to 49, and then the 16 to 17 is jumping up. 16 to 17. So you go through those groups before you ever get down to the 65 and 75 and older. Now, again, my concern is here in Northeast Arkansas, we've got a much lower rate of vaccination in those 65 and older. So we'll have to kind of wait and see what that really looks like for us. But this is the current data as we're experiencing the Delta variant in our own region. For K-12, what I've told them, you can expect disruptions. What we have seen in the Marion School District has been amazing. They started about 2 weeks before everybody else. Last check, they had 900 in quarantine. They had 59 students test positive. And 9 employees test positive. And so we can expect this will happen in our school systems that start up here in the coming weeks. Individuals that have had COVID will have some protection, and there's some asymptomatic spread. However, individuals that didn't have symptoms and didn't know they had COVID, we don't know how well their antibodies will work against COVID, against the Delta variant of COVID. Again, under 12 don't have vaccines, and we still have a lot of staff and faculty, a lot of teachers are unvaccinated, and those individuals are at high risk of not only getting it and spreading it. Recommendation is to require masking of all, limit visitors. We expect that Pfizer EUA to come out sometime September, October. Need to work on education of parents, a lot of education around the vaccine itself, a lot of myths, a lot of misconceptions. I think I could spend my entire day and night, I could have a full-time job just going through and dispelling the myths that are on the internet and on social media about the vaccine and about the virus itself. One of the things I've kind of concluded is consider the source and what do they have to gain. Many of these individuals, many of these organizations, they are money making. They are making money off of a clinic visit because they've got some sort of concoction they're going to sell you, or they need more likes or shares, and that makes them money as well for advertisers. One of the reasons I had this conversation actually over the weekend with a Yale professor that I think highly of, and he said, here's the deal, Shane. He said, I've got a day job. I can absolutely sit and answer all these. I can dispel all these. I can explain to you the research. I can explain to you why these studies are flawed and why this doesn't work. And he said, this is what I do all day long. But it's not my day job. He said to work on this. And to some respect, I think there's some truth there. I mean, my day job, whether you know it or not, is running a medical school. And so really that's what I'm normally supposed to be doing. Obviously I can't sit by and ethically or morally ignore what we're dealing with now. And so that's why I'm speaking to your groups and other groups, is to try to help dispel myths and help answer questions. But it could be certainly a full-time job. Again, avoid mixing. A lot of the same things that I've already told you about how to reduce your risk of getting it. And don't be surprised if influenza comes back. What do we really expect here in the state of Arkansas in our region? Well, let's look at other countries. In the UK and Indonesia and those areas, they peaked at about 6 weeks. So about 6 weeks in is when they hit their peak. Well, for us, that would have been, actually about a week ago. Because when we started, and I'll show you about that data in just a second. So 6 weeks from the start of the increases when they peaked. When they dropped, though, and I want you to see this in the bottom right-hand corner, is India. And that big, big peak is when they got the Delta variant. The other small one is when they got the regular COVID. Look at their baseline. So look when it came down from the Delta peak there, and see how much higher it is compared to when they started. So look, you see that early there, the January, February, March, how small that line is. And you see where the July, August is. That's my concern, is that when we come down from this, and we will, but we're going to be much higher than where we were. In the state of Arkansas, we were about 180, 200 cases a day. If we follow this group, we're going to be close to 500 to 600 cases a day at a baseline. And that's not going to be good going into the fall either, or into the winter either. The other thing to remember, the wild card behind looking at other countries, India was in lockdown. The UK had restrictions in place, and we're about to start school. And so when you look at where we were in the state of Arkansas, we started about June 15th or so. That's when we started our significant uptick. If you fast forward 6 weeks, it's about July 27th or so, which is past. But we continue to go up. We continue to increase past that 6 week mark. Like I said, there were other variables in other countries, and it's hard to compare apples to apples. I mean, really, you're lucky if you're even comparing fruit to fruit in this pandemic. Louisiana, they started their uptick in July 6th. They're not even close to slowing down. And again, the big wild card is what's going to happen when all of these kids, and not just K-12, colleges and universities start back. Here at the medical school, we require vaccination of all of our students. We also require them all to be in N95 masks. We are very much the exception. And I get that. But I mean, as a medical school, we kind of have no choice. We have to follow the evidence. We have to follow the guidelines, and we've got to get these students through medical school so they can be doctors. And so we take every precaution we can to make sure that happens. But there's a lot of unknowns. We're still debating masks, even though the science is pretty clear that they do reduce the risk of spread. I don't know why we're still talking about that. We're still working on our vaccination rate, which is still very low here in Craighead County. And some of this, and this is a whole nother conversation, some of this, of these seeds that we have sown happened way before the pandemic. With that, I will go ahead. I think that's my last slide, and I'm happy to stop and answer questions if there are any.
Dr. Speights, this is Gary Higgins. How soon after infection, somebody's been unvaccinated, how soon should they get vaccinated?
Yes, sir. So what you're asking is let's say I get COVID, I'm not vaccinated. I want to get vaccinated now. Typically, it's about 10 days. So typically, and that's assuming that you're over the infection. Obviously, if it's 10 days in and you're hospitalized, don't get the vaccine because you don't want another jolt to your system. But if you got COVID and you're sick with it now, and they're relatively mild symptoms, not bad, and you're getting over it, about 10 days after you get diagnosed with that infection, you can feel safe about getting your vaccine.
If one qualifies by age and illness, how does one go about getting a booster shot?
So what you'll have to happen is, and the reason why you haven't heard about it now is because it's not FDA, the FDA is not allowing it. And this is something I got to explain to you. Right now, the vaccines are under they're under EUA, Emergency Use Authorization, which means that a provider, such as myself, a physician, I have to follow the EUA. The EUA says I can only give the vaccine at this point. I can only give a second dose at this point. Now, if the FDA approves it, if there's full FDA approval, I, as a physician, have the ability to do something what's called writing off label, which means I could prescribe the vaccine. If I think you are at higher risk, I can say you need a third dose. You can't do that unless it's FDA approved, which brings about another conversation. When you talk about, and I hate to jump into this is going to be a wormhole, so bear with me. When you talk about ivermectin, that's how doctors can write for ivermectin. Ivermectin is FDA approved to treat scabies, parasitic worms, and infections like that. Because it's FDA approved, a physician can turn around and say, I'm also going to write it for, the common cold, and I'm going to see how it works in anxiety, and I'm going to see how it works for your blood pressure. Legally, I can do that. Is it ethical? That's a bigger debate, but legally I can do that. So for what you're asking, you will see information come out probably from your major hospitals here pretty soon. Once the FDA says that's approved, and you should be able to go to like St. Bernard's, NEA Baptist, your local physician's office and get that booster dose. I expect the FDA will come out and they'll set parameters. They'll say 65 or older or immunocompromised. When they say or immunocompromised, that leaves the door open for really interpretation, which means that for those that really want it and have a need to, should be able to get it without any problems locally.
This is Nancy Elphinstone. I'm wondering if anything has changed on the, if we're around someone who has COVID, maybe they don't even know at that point they have COVID, how long near them should we be concerned about isolating?
Yeah, it's still the 6 foot 15 minutes. And that's for, they have not really redefined the close contact, and it's on the CDC's website. They've not updated that. There's a couple of caveats to that, and this is probably why they haven't updated it. There's some MIT research that came out, early spring or late fall, that basically showed that, this COVID-19 virus is airborne, which means that as I'm standing here in my office, it's possible that I'm infecting my administrative assistant out, even though my door is closed, because we have the same air exchange that we're using. So that's kind of a fly on the ointment. There's this complicated calculus equation where you can calculate based on the area that you're in and the people that are there and where the person infected is, what your risk is. But that's why the CDC has not changed and is still the 6 foot for 15 minutes. Now, they have allowed some latitude, and they had to for schools. For schools, they said that it needs to be 3 feet. And the reason why is because if you've ever been in a third grade classroom, you can't put those kids 6 feet apart. It's just impossible. And so there had to be some common sense that went into that education. So it's still 6 feet for 15 minutes. And you would want to, if you're a vaccinated person, you would want to wear a mask. You don't have to quarantine. You'd want to get tested in 3 to 5 days. If you're unvaccinated, you need to quarantine and get tested and follow those policies.
Hi, Dr. Speights. This is Lily Fears. And you talked a little bit about misinformation. I hear a lot about the things we can do to build our immune systems. And my gut feeling is some of it is distorted, but what can we do some things to build our immune systems and add to all of the wonderful information that you've given us on how to be as healthy as we can and safe?
Great question. I'm glad you asked that. Thank you for asking that. So one of the things is, yes, there are things you can do. And it's like, if you look back at a lot of the myths and the misinformation, there's usually a thread of truth in there somewhere that's just been, expanded or taken in the wrong direction. And so a good example is they talk about vitamin D, talk about vitamin C, talk about, zinc and things like that. Well, let's take vitamin D, for example. And like I said, this is a whole nother lecture. Vitamin D is certainly important in your immune system. It absolutely is. It's vital for the function of your immune system. But the thing is your body only takes so much vitamin D. And so it's not like you can dose up on vitamin D. Okay, now I have extra vitamin D, so my immune system works extra better. It's not like that. It's like filling up your gas tank with gas. Once the tank is full, the gas just falls out on the floor or on the ground around you. Your tank can't get more full. The tank only holds so much. Vitamin D is the same way. If you get, too much vitamin D, then, it'll go out through your urine. People are hesitant. Like myself, are hesitant to say, yeah, you should take vitamin D because I've had my wife say, well, isn't it pretty much, is it really going to hurt you? For most people, it's probably not. But for somebody who has maybe kidney disorders, yeah, it could absolutely hurt you. Maybe someone has some underlying disease that in terms of processing vitamin D, it absolutely could be toxic to you. You can be toxic. Anything you take can be toxic. Now, for vitamin D, the people who I'd be more concerned about, to be honest with you, are people who live in Boston. And it's based on how close we are to the equator. We here in Arkansas are so lucky we're closer to the equator, and we get all of our vitamin D through the sunlight, through our skin. The skin actually produces vitamin D synthesis through sunlight. So you don't even have to worry too much about it getting it dietarily because we get it through the sunlight. On average, somebody in Arkansas, you just need to be in the sun about 10 or 15 minutes a day is about your daily intake of vitamin D. Now, if you live in Boston, it's a different deal. You got to be out there for an hour or more, and then depends on what season it is and that sort of thing. So those individuals that are higher risk. But that's where things kind of like a shred of truth kind of gets put in the wrong direction. The things that I recommend for people is really things that you should do anyway to boost your immune system, not just against COVID, but against the common cold, against the flu, against all kinds of things. And it goes back to, and I'm an osteopathic physician, my firm belief is your body has the inherent ability to heal itself if just given the chance. Diet and exercise. You don't have to go run a 5K today, but if you start walking around your neighborhood, you would not believe how much healthier you would be. And that's the truth. And I could explain the physiology behind that in terms of the muscle squeezing and the lymphatic tissue and how that helps your immune system. That's huge. Nutrition. Yes, I'm a big fan of vitamins. I'm a big fan of you getting them through fruits and vegetables because that's the way your body expects to get them. Your body's not really expecting it in a pill form. Yeah, it's easier for you to pop a pill in the morning. It's harder for you to eat an apple or an orange or something like that. But really, your body prefers the apple or the orange, the broccoli, those kinds of things. Now, my wife cooks great broccoli, so I shouldn't say that. But that's my point behind that is that there are great ways that you can boost your immune system that are naturally and will really help you even beyond COVID. I'm a huge fan of the vaccination because vaccines save lives. And we've got a long history of great vaccines that really prove that people will live longer. It's just funny how sometimes from a historical standpoint, we forget all that. People forget about polio. They forget about, measles and smallpox and all those things because it didn't really affect us because we did such a good job. I hope that helps.
Dr. Speights, this is Sam Hummelstein via Zoom.
Yes, sir.
So what is your recommendation on in-person meetings, going to restaurants, and other types of indoor activities?
So I'm not, right now, as we're seeing a surge of Delta cases in Arkansas and in Craighead County, I'm not a proponent of it. I'll say this, what are we doing? And I always try to give an example of what are we doing at the medical school. At the medical school, we just had orientation of our first year class. Our first year class is 120 students. Typically, we pack them all together in an auditorium and we do orientation. Now, and let me be clear, they're all vaccinated. Like all of the students are vaccinated. All 100% of this class or these students are vaccinated. We still divided them up and we did 30 per group. So we did orientation 4 times over 4 days with 30. They all wore an N95 mask, which is a mask like this. It's the highest grade mask. It wasn't a cloth mask, it wasn't a surgical mask. So they're fully vaccinated with an N95 mask. And we have felt like, and I've spoken with our researchers and our infectious disease specialists, that was safe. We didn't require them to sit socially distanced. They could sit next to each other and they could talk with the mask on. Because again, this is a hospital grade mask that we use and they're 100% vaccinated. So it's almost like you have to look at the individual scenario and decide what's the safest way we can do this. I feel so bad for K-12 because that's going to be rough. That's going to be hard. I mean, for us, we've got kind of a micro environment we're able to do this in. We can mandate we can mandate masking. I can mandate vaccination for our students, but you can't do any of that in K-12 or even in public institutions, public colleges. And so that's why I think we're going to see a significant increase in terms of the cases that we're going to see, which is what we've seen elsewhere. So I don't know if that helps or not. Does that help?
Yes.
This is Marcus Tribbett by Zoom.
Yes, sir.
As always, it's wonderful to hear from you, but also unsettling as all get out.
I'm sorry. Sorry, Marcus.
I know, but yeah, it's not just coming from you, of course. My question is, about the N95 masks. I recognize that they're the best. What do you think about the double mask option if you don't have the N95, so a surgical mask under a cloth mask?
Now, this is purely personal opinion. This is purely speculative because I'm always hesitant to do this. I prefer to be able to quote a study or quote the research. The research is clear. An N95 mask is the best. If you don't have an N95 mask, a surgical mask is good. The least option is a cloth mask. And let me be clear on the cloth mask. The cloth mask would be, and I don't have one sitting here at my desk, the cloth mask would be a 70-30 blend of a 3-ply mask. And that was the cloth mask we always used because those are what the studies were done on. It wasn't something that maybe, you made at home or something like that, or had a single layer of a pillowcase or something. It was a 3-ply mask. Now, for what you propose, you're saying, well, what if I put a cloth mask over the surgical mask? Well, in my mind, I say, well, yeah, that's going to be additional protection because you've got the surgical mask there in place, but then you put the cloth mask over it. Where things get sticky is because sometimes we think things are the way they should be, and then we find out when we do the research, they're not. Because all of a sudden we find out, well, you know what? There's actually more aerosolized droplets that then hang out in the cloth mask that are held up there that for whatever reason then interact with the fabric on the outside of the surgical mask, therefore rendering it useless. I made that completely up. I'm seriously made that completely up. And so I'm hesitant to say one way or the other. In theory, it should be better. But without actually testing it and knowing what particles are passing back and forth, it would be hard to know. So, and the other thing too, and I've seen this, it's so painful. I've seen physicians like on YouTube talk about how masks are completely ineffective and that there's no proof. I get really frustrated with that. Like we know the science behind it. Well, and here's a good example, the N95 mask, on the COVID-19 virus, it is 0.1 micrometers. It's the same size as influenza. It's the same size as influenza. And that's why we use the N95 mask because we've got experience with influenza and other viruses that size. It's not that COVID's any smaller than any other virus we've seen. And so that's why I think some of our studies have been helpful to be able to reveal that. And I get frustrated when I see misinformation like that come out. That was a roundabout answer that I don't know that it really answered. So I'm sorry.
Well, thank you anyway.
Yes, sir.
Hi, Dr. Speights. This is Lori Chandler. I was taking notes as you were talking, so I have a couple of questions if you don't mind. I know we're running a little short on time.
No, go ahead.
But the first question I have is, how are they testing for the Delta variant, or are they?
Yes. So first of all, and there was a lot of questions about that. The current testing that we use, like at the NYIT clinic and really all the clinics around this area, that testing picks up on COVID. So it will pick, if you have the Delta variant and they do a COVID test on you, it will turn positive. It'll actually turn positive pretty quickly because of the amount of virus. Like we said, the Chinese study that shows there's about 1,000 times more virus in your nose and your mouth, it actually turns positive pretty quickly. Now that tells us that you have COVID. Does it tell me if you have the Delta variant? Well, no, not really. The PCR test that we send off to the lab tells us if you have the Delta variant. But here's the deal. And I remember the graph I showed, 97% of the COVID cases now in our area are all the Delta variant. We do look for other variants where we do look for, we do some sequencing, not as much as we should be. But if you test positive for COVID here, you can be pretty sure it's the Delta variant.
Thank you. So that kind of also leads into my next question, which is that you obviously stated that the genetic makeup of the virus is changing and hence why we have a new variant. And given the positivity rate that we're having with the spread, it's probably just a matter of time before that virus mutates again and probably causes another variant. So how is the vaccine going to be able to adjust in order to keep up with the transitions of these variants?
So that was one of the cool things that we found out about the vaccines with the Delta variant was, and that was kind of the data that I was showing in terms of how effective it is against severe disease and hospitalization. You're still hitting 92 to 97% effectiveness at preventing severe disease, hospitalization, or death. And so we're seeing that with other variants too. The Delta variant is not the first variant we saw. Remember, there was a UK variant, there's a South African variant, there's a Brazilian variant. And so we had already been testing the vaccine in those countries against some of the other variants, and the vaccines do pretty well. Does that mean that it's always going to do well? No. And so I think where you were going with this, and you're right, are we going to have a different shot maybe each year, every year and a half or something like that for coronavirus? That's what it's looking like. The current data now and the research that I've been seeing kind of points to the fact that we're probably going to see COVID become what we call endemic, which means it's going to show up either seasonally or in certain pockets here and there. And that's likely what will have happen. And there'll probably be a booster shot or like you have your annual flu shot. You'll probably have that happen. I don't know that it'll be annually just because the vaccine seems to work so well. It may be every 2 years. I think it just depends on how much variation occurs. You've got a spike protein. We talked about the spike protein, which is how the virus gets into your cells. And so you have these mutations on the spike protein. The vaccine itself does a really good job of covering most of them. But what you worry about is that the virus mutates so much that your antibodies don't recognize it and that the vaccine didn't cover for it. And so there are a couple of variants that we're seeing now. They're not widely spread, but we're watching them that we have concern about their ability to evade immunity. And let me be clear, it would not just evade vaccine immunity, it would evade natural immunity. What I mean by natural immunity is you got COVID and the antibodies created from that don't protect you. And I think people miss that boat too. At the end of the day, we want you to have antibodies. And so some people get antibodies through getting infected and getting sick. Some people get antibodies through getting a vaccine. You still need the antibodies. Antibodies aren't the only piece of the conversation. There's T cells, there's other conversations that go on in terms of the immune system, but antibodies are kind of the big player, and that's why I make a big deal about them. Did that answer your question?
Thank you. And
Yes,
then my last question is, do you think that you will see a change in vaccinated individuals having to quarantine since it has been known that they can contract the virus and also spread the virus?
That's a really interesting question. That's actually a great question. It wouldn't surprise me. Like I said, and y'all saw that graph that I showed you, and that's not a very widely circulated graph. But that's known data, that's known research that's out there. I'm very fortunate. I'm gonna put a plug in. I'm very fortunate, obviously, to work at a medical school. Most of this stuff I don't get on my own. I have really smart people that explain it to me and help feed me the information. Hey, Dr. Speights, did you see this? Did you see that? And so our dean of research actually is the one who showed me that slide because I hadn't seen it before. I contributed to him there in the slideshow. But it would not surprise me because certainly I would say that they probably, the first 5 to 6 days or so. Now, I think the CDC the way they would cover themselves is saying, well, you should be masked and get tested within 3 to 5 days and know if you've got it. But then, there's a debate back and forth. I don't know. That's a really good question. I don't have an answer to that. It wouldn't surprise me, though. By the same token, I would say, well, if I'm sick and don't know it, if I came in contact with somebody, I should wear a mask, which should reduce my chance of spreading it. I should get tested within about 4 days. If I have it, then I'm out for 10 days. Is that enough to slow the spread versus I have had a contact and I need to actually quarantine? Because that's what you're saying, quarantine versus mask and go about your business. I think we would have to have data that shows breakthrough or shows individuals infecting others if they're if you're fully vaccinated, wearing a mask, and don't know that they're sick yet. But that's probably out there, though. That's a good question.
Dr. Speights, this is Claudia Shannon. I want to ask you to explain ivermectin use. You brought it up.
Yes, ma'am. No, absolutely. So ivermectin, first of all, let's talk about what ivermectin is. Ivermectin is a medication that we use. It's an old drug, used it a long time. We feel pretty good about how it's dosed, how we know how to dose it. Ivermectin is used to treat scabies or parasitic worms. And that's a whole different lecture on how humans get infected with parasitic worms. Usually it's undercooked, meats and porks and things like that, or it's, hold my beer while anyway, it's one of those things. But ivermectin is an antiparaparasitic. And the way it works is it actually binds to chloride channels in the human or on the parasite, specifically in nerves and muscles of worms. When it does that, it paralyzes the worm. And through that paralysis, the worm then dies. So ivermectin, what it does is it binds to the chloride channels on the nerves and muscles cells of the worms, and it paralyzes the worms and they die. Okay. Viruses don't have nerve cells and muscle cells, and viruses don't have that kind of mechanism. So if ivermectin were to work, it'd be by some way that we have no idea how it works. And we have no idea what dose would be needed to make it work. Now, where it's been confusing is there were some studies that were done that looked at ivermectin. And to be honest with you, the evidence is like inconclusive. So you got some studies that say, yeah, we show it works and it actually helps. And we got some that say, we don't see any difference at all. And so it gets really confusing. The other thing is some of the studies are, to be honest with you, they're not good studies. Like it looks like they maybe even falsified some of the data. And so it's questionable. Like the patient walked out on June 31st with no symptoms at all. It's like, well, there's not a June 31st. There was just really it was obvious that a lot of the data had not been scrutinized or peer reviewed is what we say. And when you have peer reviewed data, that means that you've got really smart people that look at the data and say, well, now, wait a minute, how did you get this? And show me your data set and all that kind of stuff. And on ivermectin, they would say, well, it's FDA approved, it doesn't really hurt anybody. Well, first of all, again, I'm a big fan of do not take a medication that you do not need or that you're not trying to get an intended outcome that we know has evidence to support that. And so I'm not a fan of that. When we talk about ivermectin dosing, if you look up the normal dosing of ivermectin, we dose it about once. So you take like one dose of it. Or you dose it and then you dose it about every other day or every fifth day, or you take it once and you take it again 10 weeks from now. You certainly don't take it several times a day, and you don't take it every day, and you don't take it for weeks or months at a time. And so we don't have any data on anything like that. And so the data is just real sketchy on ivermectin. What happens is, and this is going to be a long drawn out answer, so just bear with me. What happens is in medicine, and I remember this because I was very active in the hospital, very active in the clinic for many years. It is really hard for doctors and nurses and respiratory therapists and staff to watch people die. It's really hard. It's really hard. We do it, we watch it, we deal with it every day, but it's hard to watch people die, especially in the intensive care unit, especially in the ICU. So even myself, when we have tried everything that we can and everything that we know that works and everything that we have evidence and guidelines and the standards say this is what we should do, and they still are dying, then we have been known, we being physicians in the medical community have been known to try other things. And we call that the IV kitchen sink, which means we tried everything but the kitchen sink. So we might as well throw that at it. Now that happens. It happens here. It happens all over the country. It happens all over the world. Does it sometimes relate into something that we didn't know would happen? Sometimes, not usually. Sometimes it does promote evidence and promote research. And all of a sudden now it's like, hey, maybe we should look at this. Maybe we should look at that. And it's really hard to come up with these answers in the middle of a pandemic when all of your ICU doctors and hospital doctors and nurses are watching a lot of people die. And they want to try anything they can to prevent that death. But trying to take that and translate it into something that you should take as an outpatient or even take as a preventative, that's not good medicine. It's just not. It's not good medicine. It's not. We have standards in terms of how we practice medicine, and to throw those standards away during the middle of a pandemic when the population needs us the most, I think it's unethical. I do. I can see where it comes from because I've been in that situation as an ICU doctor, as an ER doctor, as someone who's trying everything they can to keep their patient alive. And so I can understand it. It doesn't make it right, but I can understand it. Does that make sense?
Dr. Speights, this is Gary Clark. I want to thank you so much for joining us today. We've taken up a lot of your time. I know you're very busy, but it's been an outstanding program. We sincerely appreciate you coming. Thank you so much.
My pleasure. Thank you for having me.
Thought for the day. Rotary changes us and those we serve. I believe we can change the world one life at a time. Paul Harris. Thank you very much.